This is the Mike LiPetri Show. We're rolling. How you doing, Doctor?
I'm doing great. It's fantastic to be on with you.
It's a real pleasure. I was so excited to see.
You've had almost everybody else. You ran out of people now, right?
Nah, we're moving, baby.
Okay.
We're all different issue oriented here. I love it. I mean, what do you think about the studio setup? You like it?
This is nice. This is pretty fancy.
You have to say that you're on my show, so you got to say it's nice and fancy. But Dr. Reynolds, it is such a pleasure to have you on. Family and Children Association President and CEO, somebody who has been a staple in mental health. Being there for our seniors, for our families, for our children, just as the name entails. I was hoping for the listeners and viewers if you could provide a little background of your CV per se, so they could see all of what you've done, because I think you've been so intertwined, not only on Long Island but throughout New York State, in the area and industry of mental health for all those different communities, that I think it's so vital to have you on today to really dive deeper into them, so that mothers, fathers, children, and the rest of the community could be aware of the ramifications of whether it be fentanyl or xylazine. Did I say that correctly?
Yep, you did.
The commercialization of marijuana, social media and our children, and the suicide rates that you're seeing that jump. I want to touch all those issues, and even more, if you think I'm missing anything, we can dive into as well, because ultimately I want to make sure that our families, that our communities are aware of what's going on. So can you just provide some background for you?
Yeah, sure. So FCA has been around for 139 years. I have not been there all of those years, although some days it feels like it. I've been there about 8.5 years. Before that, I ran the Long Island Council on Alcoholism and Drug Dependence for 9 years. And before that, I worked in the field of HIV and AIDS for 19 years. Started out in the late 1980s doing case management. And that was the first round of heroin, really. And got into this largely because of family members' involvement in addiction, and that kind of spurred me forward to want to make a difference in the community.
So let's talk about everybody wants to know about it. Everyone's talking about it. Police are saying it. Communities are saying it. Fentanyl. It's in our schools. It's in our communities. It's here. It's present. How severe is it, I guess, is the first point. How can it affect you? Is it simply, does it have to be ingested? Does it have to be orally ingested? Can it just be by touch? What is it? What really is it? How does it affect our children? How can it affect our communities? Can you explain that?
Yeah. So here are the things that you should know out of the gate. The media always covers fentanyl, and then will run a picture of like a pharmaceutical grade fentanyl package along with the copy. The reality is the fentanyl we're talking about is not pharmaceutical grade fentanyl that somebody would get, for example, in a nursing home for end of life care.
Right.
That's still used. It's very powerful. It's dangerous if it's misused. But the fentanyl we're talking about is counterfeit fentanyl. It's mixed up in a batch, usually in Mexico. It's brought across the border and then sprinkled into our communities. And the ports here in the New York metro area are a key entry point. We don't know if it comes from the airports, from the shipping ports, but it's getting into this country with almost no problem whatsoever. And it used to be that we would distribute fentanyl test strips so that users would know if they were about to use a batch that would ultimately take them out. And the reality now is there's fentanyl in pretty much every drug sample on the street, whether we're talking about heroin or counterfeit pills. We've even found it in cannabis, although that's exceptionally rare. But the reality is, I've said to folks that continue to use substances, look, there's treatment, there's another way. This is a game of Russian roulette in this day and age, but understand that there's fentanyl in pretty much anything you're going to pick up. Problem with fentanyl is it's about 50 times more powerful than morphine. And so it's a super powerful drug. And so if I showed you, Mike, a salt shaker right now, that'd be enough to take out an entire community here on Long Island. That's all it takes.
God.
It's a couple grains. And that bar between the greatest high ever and a fatal overdose is very, very narrow. When you think about it, most drugs have gone through a couple dozen hands before it ever gets to the person who eventually uses it. So I put a little bit of fentanyl in because I want you to come back.
Yep.
The next guy puts a little bit of fentanyl in because he wants to have the best brand of heroin on the street. And before you know it, 24, 36 people have put those little grains of fentanyl in it. And the person uses it and winds up dead. And so when we look at the overdoses now, fentanyl accounts for the vast majority of the overdoses out there. Generally, contamination happens through ingestion, either through injection or through oral ingestion. can sniff it as well, although very few people do that at this point in time. There have been some accounts of emergency personnel coming in contact, potentially inhaling it, getting it on their skin and then ingesting it, of having negative reactions, and that's certainly frightening. That too is the exception rather than the rule. Thank God we don't see a lot of that, and thank God for our first responders who put themselves at risk every day in dealing with this. But there's no end in sight right now, and we've seen overdoses just continue to increase, and post-COVID, overdoses are up 30%. And so before COVID, here on Long Island, and you and I talked about this in the past, 2016 was really the overdose height here in Nassau and Suffolk County. We started to bring those down, and then COVID hit. And the perfect storm here is a deadly drug like fentanyl, a stress and anxiety and depression level like we've never seen here before in the community, and in some cases, a lack of treatment even for those people who are asking for it. And that's what we're dealing with. When we look at fentanyl, it's easy to get caught up in that. And I always quickly add, as bad as fentanyl is, alcohol still kills more people than fentanyl and heroin combined. And people are amazed to hear that. They say, how could that be? Fentanyl kills you faster. Heroin kills you faster. It's, from the time you begin using to the time you suffer an overdose can be a very short period of time. Alcohol takes a much longer period of time to kill you. And the reality is, as bad as fentanyl got during COVID, alcohol use is up generally in most communities about 35 to 40%. That tracks with the increase in alcohol sales, which is really easy to measure. When people self-report their alcohol use, people tend to diminish what they use. How many drinks do you have per day? Well, maybe one or two.
Yeah,
well, it turns out it's 5 or 6.
Exactly.
Right? And so, but by all the objective measures, and here in New York State, we've taken some steps to increase access to alcohol. We basically said, hey, this is the only essential service during COVID, and not only will
Which was crazy to me.
Right, we'll deliver it to your house. You can back up your truck, and we'll put a 55-gallon drum worth of margaritas in there. You can't have a French fry,
right?
But we'll give you plenty of alcohol. Then we legalized selling alcohol in movie theaters. Yep. And I always say to people, look, if you can't go 90 minutes without a drink, you and I should have a conversation about that. And so, then add on to it cannabis. And so the reality is, here in New York State, fentanyl is the number one, stealer of lives, particularly young lives. And we're seeing the biggest increases now in adolescents 18 to 24. That's who's suffering the overdoses now. And it's not that these kids are out shooting heroin. They're buying what they think are prescription pills. Those tend to be ADHD medications. They tend to be other medications. They tend to be things that make your anxiety and your depression go away. So this is the kid who's returned to school, who is stressed out, who feels like I was a rock star and now I've lost ground. I'm just not feeling myself. And then one of your pals says, hey, I'm on meds. It made me feel better. Do you want one? And you take that pill 1 or 2 times, and then you're out on the street looking for those pills because you can't talk to your parents. The number of counterfeit pills on the street has increased dramatically. And I know a little bit about pills, and I will tell you, if you look at a counterfeit pill, whether it be a Xanax or anything else, and try to tell it from a pharmaceutical grade pill, there is zero way to tell the difference.
Wow. And
so that's generally how this gets off and running for most kids. But again, fentanyl isn't the only thing. Alcohol is a huge issue. And then, in your intro, you mentioned a little bit about a new drug that we're seeing on the street called xylazine. Xylazine is a large animal tranquilizer, approved for use in animals in the 1970s, denied for use in humans because it was dangerous.
Right.
If it feels like a familiar story, it's because ketamine too is an animal tranquilizer.
Yeah, ketamine I've heard of, and that's why it's interesting. Where now, why is xylazine coming onto the fray? Why is that?
I'll tell you, it's the demand. All of this tracks back to demand, and so there's a demand for bigger, better, more powerful drugs, and xylazine is that. And so we're seeing that. The thing that and so we've seen it in most major metropolitan areas. In fact, the New York Times did a fairly extensive package on this a couple of weeks back. And one of the things that happens when you use xylazine is you wind up with very significant abscesses on your skin.
Oh, wow.
So much so that there has been a huge amount of folks who have had amputations in the streets of Philadelphia because it's gotten so bad. So this is the thing. So it's almost like we talk about the next big thing. Well, it's already here, and it's already overlapping fentanyl. One of the key things about xylazine that makes it different and that scares the hell out of me, quite frankly, is that it's not an opioid, which means that it doesn't respond to Narcan.
That's the new. So it's a few episodes ago, we had a Suffolk PBA on, and they were indicating to me that there was new drugs out there.
Yeah.
I don't know if it was on the episode or even before it, but they were talking to me about how there's new drug out there that it completely beats Narcan, and so this is the drug.
Yeah, xylazine. I mean, with fentanyl, it's tough too. With fentanyl, law enforcement's having to use 2 and 3 doses in order to revive somebody because it is so powerful.
Wow.
But xylazine is not an opioid, so therefore it doesn't react. We always say to people, use Narcan anyway, because if that person used xylazine and something else, because you almost never use xylazine alone,
right,
then if you back out that other drug, that potentially you bring the person back to life. So then there's no downside to using Narcan if somebody is an overdose.
Yeah, I mean, at that point, it's not going to harm you any
right,
worse.
There's no loss, right? And so it's emergent, it's on the horizon. But the Suffolk County Medical Examiner has found it during autopsies, and so it concerns us, it worries us. And, you know, one of the things that is always frustrating is I feel like we're always in this game of trying to catch up with the latest drug of the day.
It's reactive instead of proactive.
Yeah, and we're always a step behind. We're always like, well, look, 12 people died. Perhaps we should look at this. And so I wish we could, at some point in time, stop chasing the drug du jour and get to the core root of what's driving all of this. And when you look at young people, it's really not complicated. It's anxiety, it's depression, it's wanting to fit in. Look, there are young people who will use cannabis, for example, use alcohol, will even try pills because their friends are doing it, there's peer pressure, that kind of thing. That's an age-old thing. But there are young people, and these are the ones that have the hardest time, who will do that and say, my God, it's the first time in my life that I ever felt normal. It's the first time I ever felt like I fit in. It was the first time I ever felt at peace. And then when somebody like me walks into a school and says, hey, you might die if you do drugs, that kid is saying, so either I feel normal or I might die. And that's a heck of a position to put a 15-year-old kid in. Yet that's what we do on a daily basis. Part of the solution to that really is making sure that there's good mental health care available for kids. And up until now, that's been a challenge.
Why is that? Where is it? Are we still facing that taboo of mental health is a problem that we don't want to speak about, as opposed to an issue that just needs attention? I mean, I've always looked at it as it's crucial to, just like anything else, is at the outset is treating and providing that help and assistance at a young age before it festers and develops and worsens and metastasizes. So I'm looking at it as a concept of how are we still missing that? Because again, from the mid-teens, 2010s, we were discussing how we were seeing that with opioid overdoses and opioid usage, and we had to focus on that. And I remember even the state level, we made moves to treat, but what has happened? I mean, over these past few years now with the pandemic? I mean, how are we not? What do we need to do? I guess let me ask you, what do we need to do?
So there's a couple things. One is we've got to do a better job of prevention. We've got to teach kids how to talk about what they're experiencing. Kids have no idea, and most adults don't have a really good sense as to how to put words to what they're experiencing and what they're feeling, right? So part of it is prevention. Part of it is, let me brainstorm with you that if you are feeling down for an extended period of time, who's the trusted adult that you're going to go to? You need to go to. I don't care if it's your coach. I don't care if it's your priest. I don't care if it's the next door neighbor. You need to go to. A recent survey found that 60% of kids had seriously contemplated suicide within the past 12 months. That's a referendum on what we're not doing, if I ever heard one.
Yeah.
So part of it is prevention. The other piece is treatment. If you or I, either one of us, left here today and said, I need a psychiatrist for my child,
Yep.
and you called any of the major adolescent psychiatrists here on Long Island, your appointment and your child's appointment is probably going to be somewhere in May or June because they're that backed up. Lots of bad things happen to kids over the course of 3 or 4 months. And so one of the problems with this system is that psychiatrists don't go into adolescent medicine because, quite frankly, the insurance reimbursement isn't there for this. And so hospitals, including my friends at Northwell, have closed down psychiatric beds because the reimbursement isn't there. And quite frankly, if you want to stay afloat as a not-for-profit hospital, you got to make money sometimes. And so we've seen a lot of the inpatient psychiatric beds closed. I mean, here across New York State, quite frankly. In the 1970s, 1980s, the state said we're going to deinstitutionalize folks that have mental illness, and we're simultaneously going to care for them in the community. State, in typical fashion, only did half the job.
Right.
They closed all the beds, and they didn't invest in those community-based services, which means that you had a whole bunch of people with a whole lot of problems out there in the community. We have a similar type of thing now where nobody wants to put a child in a hospital. There are still hospitals that exist, but nobody wants to see a 15-year-old in a straitjacket behind a locked door. But we've got to do something for them. And that's where we haven't seen the investment in good mental health care for adolescents in decades. And so my hope is that COVID begins to open our eyes a little bit and say, look, anybody can suffer with a mental health condition. It's the state of our nations and our states' adolescence is worse than it's been in my entire career. I've been around for 30 years. It's as bad as it's ever been and worse. My hope is that that becomes a springboard for having some renewed conversations about how do we work with kids early on, meaning not when they're 15 and have big person problems,
Right.
but when they're 5 and 6 and 7. How do we do that values clarification? How do we teach them how to ask for help? How do we teach boys and girls to ask for help? The other thing, and you and I talked about this before we started, social media doesn't help. And so
social media is I saw some statistics about teenage girls and young girls. The suicide rate, I think, was through the roof.
Yeah, I can guarantee you they're higher now.
Oh, yeah.
And those are reported. What doesn't get reported are suicide attempts. And basically, families aren't big on those being reported out publicly.
Here's a study. This is on verywellhealth.com. It says a 10-year study found that a high level of early social media and or television use in early adolescence, followed by increased use as children get older, is the most predictive of suicide risk in girls. I mean,
it's a huge issue.
That is insane. This is a 10-year study that has been following to show how the effect it is. Why do you think it is among the females? Is it because of the comparison? Is it because body shape? Yeah, body imaging.
It's body
shape
images.
Has to be, right?
Right. So if you think about adolescence, right, and brain development, that critical period of time from like 11 until 16, there's a whole bunch of stuff going on. In fact, it's probably the most important time in child development besides infancy. And so there's a lot of stuff going on with your brain. There's a lot of social and emotional learning that's supposed to happen. And honestly, that's the point in time where we began to formulate kind of our core values, what we believe, how we think, that kind of thing. If you take the garbage diet, the junk food diet that is social media, and plug it into your brain, you can only imagine what's going to happen. And that's exactly what we're seeing. It's as if our kids sat around eating junk food all day and just consuming it almost 24/7 in rapid succession in 10, 15, 20-second videos. That's what services like TikTok are doing to our kids, disproportionately girls. I think for boys get bad ideas from TikTok and they do things that they shouldn't be doing. Girls, I think, get bad ideas about themselves. And so they look at the attractive, young woman down the block
who gets 1,000 likes or
right,
2,000
exactly,
likes
right.
or 3,000
well,
likes.
and because she acts in a provocative kind of way,
Yep.
she gets the comments, she gets everything else like that. And so what's the message? Hey, if you do this too, you're going to be cool. The problem is, and I say this to young women all the time, it will never be enough. And your self-esteem doesn't come from TikTok. It doesn't come from social media. It doesn't come from some guy that has a duck as an avatar. Right? It comes from in here. Spend more time in here, and you're going to wind up with a better outcome. But it's gotten progressively worse over time, I think.
Do you think that as a country, as a state, we should limit the age that children can access social media?
Honestly, I think that's a parent's job. I'm a big proponent of parenting, and I see too many parents who just hand their kids a phone or an iPad because they don't want to be disturbed. Look, there's always been threats in our community to our kids' well-being, whether it's cars speeding up and down our block and you make sure your kid doesn't cross the road without looking, or this. This is the latest iteration of that entire thing. And I think absent any kind of government action, which is tricky, right? When we talk about private enterprise and we talk about media, it's tricky to put limits on that. But parents always underestimate the amount of influence they have on their kids. And I say to parents all the time, you're not your kid's best friend. You're their parent. Act like it. And sometimes that means saying no to things you might otherwise say yes to. Problem is, mom and dad have their heads buried in the phones as well. So they can't tell their kid to take their head out of their phone.
Right.
And so part of this is, are you doing what you say? Are you mirroring good behavior? Are you putting down your phone for 10 minutes and talking with your child so that they're not soaking up the latest round of TikTok videos?
Right. I'm wondering, in your occurrences, when you speak with children, when Family and Children Association treats those in need, do you find that the children reveal that they're not talking to their parents, or they're not having that sense of communication?
Oh, completely shut off and alienated. Even during COVID, like we all thought, oh, they're going to get together and play family games,
they're
that
home.
kind of stuff. They're going to have a great time. No. That lasted 2 weeks, and then the novelty wore off, and everybody wanted to kill each other. And so, as the parent of teenagers, I will tell you, kids will always retreat to their rooms, right? They would be content to stay in their rooms 24/7, the light off, TikTok on, right? As parents, it's up to us to say, yeah, no, that's not going to happen, right? And if need be, to drag them out by the phone. And so the reality is, yeah, I think kids will naturally move over to this, just like you and I did when we were kids. We played video games all day,
all the time,
right? But a parent stepped in and said, okay, you actually have 20 minutes left and I'm shutting it off.
I was forbidden from playing video games during the spring, summer, and fall because you're going to be outside playing.
Right.
And then the winters, you could have it for a certain amount of hours, and that's it. So you were restricted for that.
And we didn't for a second go past the cutoff because the plug would come right out of the wall for a really long time.
There goes all my progress, just gone. I can't tell you how many times I've been threatened. You have 1 minute. And I was like, I just need to save this. Hold on, Mom.
Right. Yeah. So I think some of this, parents need to understand the damage that's happening to their kids. And look, anytime in any school district, a guy passes by in a white van and calls out to a kid at a bus stop, all the robocalls go out and everybody goes nuts.
Yeah.
And rightfully so. Your enemy isn't the guy in an unmarked white van. It's the TikTok videos.
Wow.
It's the self-medication. It's your own behaviors that show your kid, look, when you have a rough day, the idea is to come home and have a drink and it makes it all better and that kind of thing. We're looking for an enemy in an unmarked white van when, in fact, we could protect our kids from some of the worst things in life by having early and frequent conversations with them.
Now, you just kind of touched on this just briefly. The alcohol what, if any, effect does it have when a parent has alcohol in the household on their kids? So when they're having glasses of wine a night, how does that impact the children? If they're having a scotch or whiskey or bourbon, does that have any impact or direct correlation at all, or causation from any studies you've seen?
And it depends how you drink, right? If you drink excessively, then it potentially has an impact because you're less able to say to your kid, don't drink. Right? Because they're going to say, Dad, you do it.
Right.
Really, what's the problem? What I mean by how you drink is that if you come home after a long day and say, what a day, I need a drink, right? And you say that time and time and time again, you've sent a message to your kid that when you have a hard day, what is it you do?
Yeah, you
pick up a drink.
You're conditioning.
Right? And then you go to the refrigerator where the vodka is next to the popsicles and the freezer. You get on a plane and you pop a Xanax and have a glass of wine. And so our kids take all of this in over time, and that actually becomes more important than the things we say. The other scenario that I see, probably because of the work that we do at FCA, is that very often there's a family member who is struggling, openly struggling, shows up at the barbecue drunk, that kind of thing.
Yeah.
They become kind of the laughing stock and the funny guy, right? Everybody jokes about it. Yeah, he's drunk again, that kind of thing. That kind of light approach to someone that has a problem, really kids take it exactly the wrong way. If they take it in that if you want to be the life of the party, you want to be funny, you want people to kind of laugh along with you, then this is what you do versus, that's Uncle Paul and he's got a really serious problem. Maybe we should reach out and try to help him kind of thing. And so, it's not one conversation, it's a series of conversations. And I think that one of the best things parents can do early on is just kind of lay out and say, this is what our family stands for. These are our core values.
Mm-hmm.
This is what we do. This is how we communicate with each other. By the same token, I also say to parents, if your kid has a sip of beer and comes home and tells you, if you punish them for 5 years after that, you're going to close down the lines of communication. So it's a fine line. You want to signal disapproval. You want to talk a lot about what you stand for and what you don't. But you want to keep the lines of communication open, because very often kids don't know who to go to talk about this stuff.
So now, speaking of that again, with the talking, going back to the elementary years for children, and where we want to nip in the bud and provide for some prevention methods and solutions for the children. Would it be an option then to have more social workers or therapists in the schools as part of the, I don't know, is it are you working for the school then, or are you working with nonprofits who then provide these resources?
I think it's both.
Okay.
So there's a lot of school districts who have hired up their own staff. There are school districts where FCA comes in via contract and provides those services. I will tell you, and maybe it's just my bias, but I do see that sometimes families and kids will tell outside social workers things they won't tell the school social worker. Same thing with parents in terms of disclosing your kid has a problem. Parents, I always say to parents, have you talked to the school? And they'll say, no, I want to keep this private. And I will say, the school is potentially your best ally in all of this. And if we're all part of a team working to enhance the life of your child, they need to be part of the team. Tell me why they're not. Tell me what the reluctance is. Well, our family's never had problems like these. And stop. This is a life or death situation potentially, and we need to be able to have those conversations. So whereas families shy away from that school disclosure thing, I always encourage it and say, look, we need every available tool in the toolbox to begin to work with your child in a way that's productive. If you don't want to, and ultimately it's your decision, all good. But having everybody on the same page goes a long way. And
how does the rates, the state Medicare Medicaid rates,
mm-hmm.
how does that affect into your job, Family and Children Association's job, and then also just the surrounding? Because you alluded to it earlier, and now dovetailing off of having these extra workers, how do those rates intertwine with having workers or hiring staff, etc.? How does that all? Yeah. How does it all intersect?
It's not even the Medicaid rate so much. It's the private insurers.
Just the
private insurers still deal with diseases below the neck and above the neck in very, very different ways. And now, especially in the past couple of years, we've seen parents who have pared down their insurance plans because they've gotten so expensive at work, and so they drop down a tier in terms of the insurance plan they take. They've got deductibles that are through the roof. They've
Mm-hmm.
got co-pays. And we spend a fair amount of time fighting with insurance companies to get folks admitted into treatment. I'm not a big fan of inpatient treatment for substance use disorders or mental health conditions, but sometimes it's warranted. And even when it's warranted, given all the change that's happened here in New York State, we still have a hard time getting folks admitted into inpatient facilities. And then once they're in, the average length of stay is like 7 to 9 days.
Is that even worth it then?
No, it's not. It's not. So what happens is...
What would you need for that? What would be the inpatient?
You probably need 30 days, but it depends on what you've been doing,
Of course, but...
If you've been out on a run and struggling for a year, then even 30 days is a pretty short amount of time to try to fix that for you. And what happens is, if you're there for 7 days and then you're discharged, not only is it a waste of money for the insurance company, because you're going to have to start all over again. It's a pretty good bet.
Right.
But for the individual and the family, the individual's like, tried treatment, I guess it didn't work. It just doesn't work for me. I screwed up again, right? And there's nobody who hates somebody living with addiction more than themselves. They'll tell you that. For their parents, it's like, see, nothing works. And they throw their hands up and they begin to give up. So it erodes the confidence. So financially, it's a disaster, but it also destroys everybody's confidence to actually solve this problem and get through it.
Right.
And again, that's whether we're talking about mental health conditions or substance use disorders and overdose. And quite frankly, the biggest risk of overdose is when somebody leaves a period of abstinence. And so If somebody's incarcerated for a short amount of time
Mm-hmm.
and they go back to using, they got no treatment, they leave jail, they party it up, they use again, they're at higher risk for an overdose.
Right, because you're also using the same quantity that they were before incarceration.
That's exactly it.
Or
Your
before
body
abstinence.
tolerance has changed. So if
Yes.
you go into treatment for 8 days and then it didn't work and you go and use again and say, well, this is what I usually use,
You're in trouble.
surprise, yeah, you're in trouble.
Wow. So, I mean, this is what I'm saying. It's a whole myriad. So how does government step in on this? What is the solution then with all these myriad of issues? And then I want to dovetail off of now this question into commercialization of marijuana and how that affects the youth because it's been legalized now at the state. But before we get into that, what if anything can the state do to at least support and support preventionary methods, but also the same token providing options for inpatient treatment and beyond that are actually focused on curative care and not just simply a Band-Aid solution?
Yeah, there's a couple things. You know, the governor announced $1 billion in new mental health money in her budget. We were happy to see that. A lot of that is capital investment and not programmatic. You know, what we always say is when money is announced, make sure it gets out the door because lives depend on it and people are dying day in and day out. So every day you wrap these dollars up in red tape bureaucracy, we're not saving lives with it. You know, the second thing is we've got to invest in more services, and we've got to invest in services that are proven to be effective.
What would be that?
You know, when it comes to prevention, there are probably 36 evidence-based interventions that have been trialed out nationally where the data says they work. Even the stuff I've done together with you, where we go in and we talk with kids about the dangers of drug use, and we have a half an hour and we scare them to death, and then, you know, we leave. That's not really good drug prevention. That's raising their awareness, but that's not prevention. Mm-hmm. Good prevention is sustained, it's hands-on. And if you want to do it right, you empower the school district to do it. You engage parents in that process as often as you do the kids. And you bring in some outside organizations to say, let me give you an outside perspective. And by the way, if you need help, we can help you. The only reason I do school-based programs anymore, because, you know, 45 minutes isn't enough to really change behaviors, particularly in adolescence, is because every time I do it, and I give out my email address, I give out my cell phone number, and folks know how to find me on social media. If I talk to 400 kids, it's a pretty good bet that at least 10 of those kids after the program will reach out to me and say, I didn't want to say anything, but.
Yes.
And it's usually my mom, my dad, my brother, my best friend, and I'm afraid I'm going to jam them up if I tell somebody. It's basic kind of stuff. And so kids and young people are hungry for someone to tell their story to, and they're hungry for help. So making more of that available, I think, is critical. And then on the mental health side, same thing on the substance use disorder side. The state's taken a couple runs at addressing insurance company abuses. The job ain't done because we still face that day in and day out. I looked the other day and said, how much does it cost us to bill out insurance companies? We spend about $278,000 a year just sending bills to insurance companies, the vast majority of which won't be paid. And I'm like, this is craziness. We also need to make sure we have a workforce. One of my biggest challenges right now, when we have, probably 35 open positions at FCA, is that traditionally the amount of money we've paid social workers isn't all that competitive. And so people who are disproportionately female, 80% of our staff are female, disproportionately people of color, disproportionately low-income folks go into social work because they maybe experience something in their own lives, and they want to make a difference and make sure those same things don't happen to other children. But you can't make a living on Long Island doing some of this stuff.
What's the starting salary now
for us? It's probably between $40,000 and $50,000, depending upon your level of experience, and it's hard work.
Yeah.
And so if you're a clinician in one of our clinics, it means seeing probably 7 patients a day. And they're really challenging folks. And so, one of the things we've said to the state is announcing all of these new initiatives is phenomenal. But the governor in her proposed budget this time around included only a 2.5% cost of living increase for social work staff. CPI is closer to 6 or 7, and before it was 9. And so we've got underpaid folks that have historically been underpaid, and now we're not even going to help them keep pace with the
Inflationary
with
issues, yeah.
inflation. And then we wonder why people don't stay in this field and they go on to do other things.
Right.
So I lost people around the holidays who said, I'll go work at Amazon, I'll go work in retail, I'll sign up with one of the telehealth services and maybe do some sessions at night and work with folks that maybe are a little bit easier. That's a tragedy because now more than ever, we need them. It's almost like there's a raging fire and I've got people who are packing up and going home instead of running into the building to help those who are struggling.
Yeah, because how they're looking at it is I have to endure all this pain and anguish
Yeah.
to help people, but at the same time, I'm barely making ends meet myself.
Yeah.
Especially with the cost of living now in New York
Yep.
and to survive here on Long Island. I mean, you have to have that pay that keeps up with it, and then now coupled with the federal issues of inflation. And I find that a tragedy in of itself. And I think that's something that should be cognizant, hopefully, over these next forthcoming months, in the forthcoming years, definitely that gets that you find equity in that respect. So to garner more. Is there a way at all to work with I guess different schools to try to push push more students to go into the industry? Is that something?
Yeah, so there's a couple things. The state is piloting some new programs for peer educators. They're piloting some new programs for folks to get the KSAC credential, which is basically the substance use disorder counseling credential. And a lot of the schools have really good programs. We do a lot with Post. We do a lot with Hofstra. We do a lot with Nassau Community. So there's a pipeline. But the problem is there's folks that desperately want to do this work, and then they look and they say, but I can't afford to. Can I just maybe volunteer with you for a couple hours a week? Wow. And so it's no longer a career path. The other thing, and I'm sure you've talked about this on your show, people are leaving Long Island in droves.
Yeah.
And so that whole younger workforce, it just doesn't exist anymore. I can't tell you how many staff I've lost where they've gone to other regions and just said, my spouse and I are calling it a day. We just can't make it here. We're going to go somewhere else.
Going now to recreational marijuana. Legalization in New York State. Obviously, you and I both know there are some strong concerns given not only the testing or lack of testing for DUIs, but also the ramifications it would have in terms of the youth and among children in schools. I wanted to hear your thoughts exactly what, if any, effect legalization of marijuana has had towards children with early onset use. Has there been medical problems as a result of accidental use or ingestion? But also, what, if any, effect does it have on, say, fentanyl or opioids or anything? Is there a correlation or not? So I wanted to kind of hear your thoughts on all of those.
Yeah, so we were not supportive of cannabis legalization. It's ironic. We were in the middle of a major drug epidemic, and we saw rising uses of cannabis among young people. And so simply saying, okay, let's just give up and legalize it felt like a counterintuitive move. But we tried to do, I think, the best we could with the law. I think the state and the rollout of the cannabis law has not been successful. And so this notion of we'll just tax it and regulate it and everything will be okay has not come to fruition. I can tell you where there's a dozen stores on Long Island that are operating illegally right now, right here at this point in time. And so just legalize it and then we'll regulate it and be able to control it is a fallacy. It didn't work that way in other states. It's certainly not working that way here in New York. The delays last year gave the illicit market time to gear up and actually begin to put things in place to cash in before licensed stores could. There's features of the cannabis law that I don't think are great. The notion that if you break the law or have broken the law, you move to the front of the line is something that's pretty unpalatable for me. I've asked the question publicly that for folks that are opening illegal stores now, do they automatically move to the front of the line in terms of getting a license? Because they shouldn't. If I had a liquor license and you found me serving underage kids, you better believe I wouldn't have a liquor license anymore and I'd never get one again. I'm not sure why this is that different, but it is.
That's a great analogy, actually.
We also had said to the state, look, if you're going to do this, we don't think it's a good idea. It has public health implications that you're not addressing. But you should, before legalizing it, roll out a major PR campaign to say to people, just because it's legal doesn't mean it's safe. And it's particularly risky for folks who are minors, adolescents in particular. It's particularly risky for folks that are pregnant. and I've seen cannabis recommended to pregnant women for morning sickness, which is certainly not good advice. They should have done a PR campaign around driving while impaired, because any major highway you travel on Long Island right now, all you smell is weed. And we should have done some counseling around mental health issues and how this isn't a reasonable replacement for good psychiatric care. And I recommended to the state they spend $5 million getting the word out before any stores even open. They chose not to take my advice, as they often do. And we're in a situation now where we have seen an increase in pediatric ingestion of edibles. Edibles pose some very, very specific challenges given their THC content, and given the fact that the state tried to say and has tried to regulate that producers should not be making anything that looks, feels, tastes like children's candy. And they're doing it. They're doing it left and right. And so you have parents that are using edibles that are zoned out, that leave the edibles on the table, looks exactly like candy. A kid picks it up, ingests it, and they're off to the emergency room in a best case scenario. Same thing for pets. There's been an increase in veterinary emergencies among pets.
Oh, wow.
We don't yet. There's two things that we don't know yet. I will tell you anecdotally, and when you look at the treatment admissions in New York State, there's been an increase related to cannabis admissions, only among young people. And so we used to see cannabis admissions for middle-aged folks. You don't see that anymore because their attitude is, it's legal, what's the problem? There's no criminal justice kind of hammer and stick to kind of drive them into treatment. So those folks are gone until such time as their problems become more severe. But we have seen an increase in adolescent cannabis use.
What's that age group? Adolescents?
I'd say generally 12 to 17.
Oh, okay.
Yeah.
Yeah.
And the other thing and this has happened in other states too, the frequency of use has increased. And so you used to have this cohort of young people who used it occasionally, used on the weekends, used when they were hanging out with their friends.
Right.
We're now seeing folks that are using multiple times per day. They're vaping it in school, and because there's no odor to it, they can actually do that. And we're seeing engineered THC levels that are much higher than anything we've ever seen in the past. And so I always talk to folks who are my age and say, oh, you remember weed, that kind of thing. This is not that weed. This is a whole different ballgame.
Stronger.
Yeah, it's a lot stronger. It's exponentially stronger. And this is not a guy who grew a few plants in his backyard and decided to share it with his friends. This is big industry.
Because here's the thing, is everybody that currently smokes it, their attitude is, I use it to relax, to help cope with anxiety, to de-stress. I've spoken with those mothers who have expressed that I was not feeling well, and this helped me as well. Marijuana. Now, it wasn't, I don't know if they were pregnant. I think it was post-pregnancy, but regardless, like through where they had sickness and whatnot. So they've used marijuana to help cope with that.
Yeah. So, which, honestly, I don't think that's the end of the world, right? And so if you have 25-plus-year-old folks using cannabis in the privacy of their own home, and they're not going to be driving a motor vehicle, and they don't have significant parenting responsibilities, I don't think that's a big deal. I don't think that's any different than having a glass of wine. It's no different. Where we wind up with problems is when we talk about kids and we talk about access for kids. Where we run into problems is when we talk about, most of the world doesn't believe that driving a motor vehicle while high is the same as DWI. Right. And so when I ask that question in schools and say, how many of you would drive drunk? Everyone's like, no. When I say, how many of you drive high? All the arms go up. And
really?
I say, how come? And they'll say, well, because I feel more chill. I actually think I'm a better driver.
Wow.
Well, that's a terrible answer, because operating a motor vehicle is the most complicated task we do all day, especially on Long Island.
Yeah.
And so educating folks about that is significant. We've basically said to law enforcement, we're going to legalize this. We're going to give you zero tools to enforce any laws, right? So there's no way to tell whether or not someone is truly impaired with any amount of precision. And I've had very well-meaning, concerned folks who have said to me, I smoke here and there. How long should I wait before getting in the car? And I will say to them, I don't really know. I do know when it comes to alcohol, because we have 40 years worth of blood alcohol data where I can tell you this is when you're going to blow a 0.08.
Right.
2 drinks per hour, you should be in good shape. You shouldn't drive after consuming any alcohol. alcohol because it diminishes your ability. But this is the basic barometer. And then folks are like, all right, well, I want to be responsible. I don't want to hurt anybody. I don't want to be arrested. And they'll try to do the right thing. With cannabis, we have no rule of thumb to give them.
Right.
And if I say to them, just wait till you feel okay, well, we know how that worked with alcohol.
Yeah.
So I worry a lot that we've moved, that the policies are so far ahead of the technology, and that the policies are so far ahead of where we are in public health, that this is not going to be a successful experiment. And in other states, it hasn't necessarily been all that successful. I will say, and folks will say, well, the sky didn't fall. The sky didn't fall, right? But there are things that concern us and things that worry us, and there are ways to mitigate the harm that we're actually not doing the way we should.
Yeah, it's kind of ironic, too, because policy is usually leaps and bounds behind the technology. Here, it's the opposite, where, interestingly enough, is that the policy is legalizing before we have the longitudinal studies, before we have the technology for testing, for example, and then even being able to track, right? Tracking the businesses and whatnot who are operating illegally, and then enforcing such said laws, etc.
Right.
We're loosening it up. I find that quite interesting and concerning in the sense of how it's going to develop over the forthcoming year and years, which will, what if any ramifications will have. Specifically, I thought that was interesting too, how you said about the vaping. Yeah. How more and more, for us, we think about just smoking marijuana would just be through a joint or whatever. Now, it's through these e-cigarettes where you don't even know it's even you're smoking the THC, and that in of it can create that whole allure, specifically in schools where now in classrooms you're the cool kid, right? You're smoking. Right. It's almost an effect we've regressed back to the cigarette days. Right. We're kind of repeating the past where now we're having cigarettes again, where cigarettes were cool and everything. We find out this is a big problem. Well, now we have a next gen of e-cigs and vaping and marijuanas. That's the cool thing, except, well, it's going to be a problem for in the next 10, 20 years we're going to see. Because now we'll have that data to support.
Right. There'll be a whole kind of press cycle around secondhand smoke and kids who are exposed to cannabis in cars. There'll probably be a press cycle around...
Yeah, do we know anything about that, the secondhand?
We don't. And I will say the traditional use of cannabis flower has actually dropped, right? Edibles are just cleaner to use, potentially less threatening on your lungs, right? Although vaping isn't good for your lungs. So there's been a drop in smoked flower just because it's imprecise and all sorts of other things. And so it's not like it used to be, but there will be a press cycle, I think, about the negative implications. The thing that worries me the most, and I've seen this movie before, is that, big tobacco made a whole bunch of money, and then communities and specifically hospitals were left to clean up the mess, and families were left with the wreckage, and they left all the way to the bank. The opioid manufacturers did the same thing, although they're now paying some of that money back, but they left all the way to the bank, and I've got lines out my door, and I'm trying to fund this thing on a shoestring budget. Cannabis pretends to be the same thing, that when I look at it, I'm like, so a whole bunch of guys who look, act, and talk like me are going to make a whole lot of money, and I'm going to have cannabis users at my door saying, hey, could you help me? My Medicaid isn't good anymore, and what could you do for me? Gambling is... potentially it's the same thing. So I look at government and I say, so you're our allies. We're in this together. We have a mutual interest in public health, and Medicaid is the single largest driver of costs in New York State and in both counties. When you look at the Medicaid expenditures, they squarely are lodged around substance use, mental health, and medical conditions that are intrinsically connected to those things, whether it be heart disease driven by obesity, which is driven by depression. And I'm like, so we're in this together. We have a mutual financial interest, yet you legalize alcohol in every possible setting. You legalize cannabis. You're expanding gaming opportunities at every chance you can get, and you're not giving us the resources necessary to clean up the mess. And so that's a prescription for disaster. And so, for me, this is the latest in a set of things the state has done, which has actually made our job a little bit harder. And look, there might be some social good that comes out of cannabis legalization, but there's also some public health threats and some public health harms that have to be addressed and have to be cleaned up for this segment of folks that are going to fall into a problem and need some help. Yeah, well, I assure you this is just the first step of many in terms of battling. I mean, what you just said is absolutely true. The three biggest cost drivers for Medicaid, which is one, I think it's close to $100 billion, if not $100 billion right now for New York State budget.
And the three biggest cost drivers: obesity, addiction, mental health.
Yeah.
And you're totally right about that. So I think this is the first step of many to treatment, finding a solution, finding a cure, helping those in need. For those that are listening, or family that knows, and they're asking for how can we help, where can they go to, Dr.
Yeah.
Reynolds? Where could you direct them to seeking that help? Who could they call, email,
Yep.
social media? Where do they go?
We're everywhere. So whether you need help or want to give us help, both are certainly welcomed. Our website is fcali.org, as in Family and Children's Association of Long Island.org, fcali.org. We're all over social media, FCA. Not hard to find us on Facebook. We're not on TikTok. But Instagram, Facebook, Google us, get in touch with you. I'm easy enough to track down.
Easy.
Look, and if you're out there and you know someone who's struggling, by all means, hit me up. I'm more than happy to help.
Is there an email that they can reach out to direct or anything?
Yeah, jreynolds@fcali.org. Just Google me, Jeffrey
Yep.
Reynolds, FCA. I'm easy enough to find. Call me. I'm more than happy to help you. No reason to do this stuff alone.
Exactly. Thank you so much, Doctor. You're privileged.
My
It's a
pleasure.
pleasure. It's a privilege to hear from you, and I hope people really learned from all what you had to say today. So thank you.
Great. Thanks for having me on.
Thank you.